So tēnā koutou, tēnā koutou, tēnā koutou katoa, ko putua ki te maunga, ko whakatāne te awa, ko English, Irish, Scottish, te iwi, no whakatāne aho, ko Oti Pōti, tōku papu kāinga, ko Carol Atmore aho, he rata whānau aho. Nō reira, tēnā koutou, tēnā koutou, tēnā koutou katoa. Thanks for the opportunity to share with you some of my reflections about where we are at with the health system reforms and particularly how they apply in the primary care space. And I'm just going to talk about the reforms in general, more from a primary healthcare perspective, and then about my thoughts on how that applies locally, and then some few final comments at a national level again, and then some time for questions and comments. So it's a great pleasure and a privilege to speak after David. So we first met on the West Coast when I was a junior house surgeon, and he was a service manager there, and then again on a study tour led by Chris Ham in the mid-2000s. And you'll see from this photo that, well, I'll leave it to you to decide who's winning the greying hair race between David and I. But I'd have to say David is probably the best boss I've ever had, and much of what I've learned about clinical leadership, I've done that from and with him. So it's, as I say, it's a real privilege to speak after you, David. So I think this might be a way of summing up a lot of what David has said. So I bought 2 books of poetry in my life in my 20s when I was testing that side of myself out, and one of them was by Steve Turner, and history repeats itself, has to, no one listens. So I'm just kind of putting it out there in our mind as I go through. So the big reveal in April 2021 about what was going to happen with the health system reform. So, you know, a change in structure, as David's outlined, and there were 3 and the commissioning and provision of health services in that hospital and specialist care and primary and community care had a different approach to how they would be commissioned. So for me, the 3 things about this that got me really excited, actually as part of the reason now why I'm moved out of the university back into health services clinical leadership roles. So I want to cover those 3 things off next. So have you ever seen a Minister of the Crown talk about a policy direction on video in Māori and in English, and you can choose which of those you want to look at? So I think the Māori Health Authority has the potential to be a real game changer in Aotearoa, New Zealand, in terms of the focus on equity that we've been talking about for a long time, actually doing some real tangible opportunity to make that better. So I thought that was pretty cool. The second thing, despite David's and I do understand where you're coming from, and I agree with you about disconnecting commissioning and provision has got risks. I think from a general practice perspective over the years, the problem is that the hospital always gets the lion's share of the DOSH, and primary care and community care ends up having the what's left over. And so the potential in the reforms is that the split between the pot of money that funds primary and community care and the pot of money that funds hospital care is clearly delineated further up closer to the centre. And there are absolutely concerns that brings, but it does also bring an opportunity for more funding to be available for care in primary and community care. And I know that there are pros and cons of that, but that was something that got me quite excited about what the reforms may be able to offer. And then the third thing that got me excited was a clear focus on locality networks and care, which is the care closer to home concept, which is what I think we were really building on the West Coast over the time when David and I were working in that space was about connecting. We were, you know, in essence, we were working towards putting a locality networks approach on the coast, as was in the Canterbury space as well. So there are these 4 anchoring points to the locality network. So the first is around the wider socioeconomic determinants of health, for example, housing, employment, and looking at inequalities in wealth and power. The second is around the, excuse me, the health behaviours and lifestyles aspect that's outlined there, for example, smoking, activity, nutrition, drinking, gambling. And the third is around adapting places and communities, for example, the natural and built environment, as well as having an integrated health and social care system. And again, it's not just a health system, but it's a health and social care system, which goes further out into people's lives than just a health system does. So those are the things that made me hopeful that there is potential in this round of reforms to actually have something that better meets the needs of our communities. So thinking about locality networks in terms of what we know, so the locality plans are to be developed locally by communities and iwi Māori partnership boards. So every locality will have a consistent range of core services, which is outlined back in the Health and Disability System Review documents, which is a list of 20 plus things that need to be in place, and it's all, you know, makes very good sense. And that Health New Zealand and the Māori Health Authority will jointly commission the services against the locality plans that are developed. But there are, you know, the unknowns so what will the governance and leadership structure look like of a locality network? How will it be pulled together? You know, who will have different roles? Will it be health providers? Will it be local, territorial local authority representatives? Will it be community-based? Will it be elected? Will it be appointed? What's the connection with the iwi Māori partnership boards in true partnership to make those work? And then who will be accountable? So if things don't work out, who holds the accountability? And then how will the relationship between the communities and the iwi Māori partnerships boards actually work in reality? And how much local autonomy will there be? I recall with the locality plans when I was an elected board member on West Coast District Health Board in the early 2000s, one of the issues for us, and we were essentially a locality, we were 30-something thousand people, but so much came down from central government of what we had to do that there was actually very little space for what we wanted to do because of the funding constraints. So those are some things to think about. This is a slide from Martin Hefford's presentation to the GPCME conference North in Rotorua in June of this year. And this is sort of another layer of the thinking around what an operating model for primary and community care might look like in these locality networks. So they're talking about having an enhanced core primary care team. So that is what we might call general practice plus. So our current approach to providing primary health care, of late, there's been, particularly in the mental health space, the health improvement practitioners and health coaches and navigators roles, kaiwhena roles coming in to the core primary care team. So it's about, thinking who are the next lot of people to become part of the enhanced core primary care team. And then having locality provider networks, which is those enhanced core primary care teams starting to reach out to the services in the community that they should maybe be having, you know, a close connection with, for example, aged residential care, district nursing, oral health, primary birthing units, maternity care, and then how all of those things link together under provider management, network management. So coordinating, enabling, looking at the clinical governance, quality improvement, workforce planning, and then that group interfaces through the locality network with the Health NZ locality commissioning team. So these all look really good on paper, make sense at a level, but again, it's this question of how do we make that work in reality. So for example, we know that the current funding model in primary care isn't really working. And I know that that's talking about funding, but it's a reality. We have provider network management like organisations currently, they're called PHOs. They're not mandatory in the new environment, and what will be the, what will be their role in the future. Kaupapa Māori services have always got the smaller slice of the smaller pie. So if we say primary care, get the smaller slice of the pie, the Kaupapa Māori services get the smaller slice of that pie as well. And in mental health services, with our recent review down here, that was clear as well. Enhanced primary care teams are the direction. So general practice, critique of this by some people is that, counting how many times the term general practice is mentioned in the new documents, and it's a small number. So so what will a new funding model look like, and what will the new provider network management look like? Will PHOs morph as they did from the Independent Practitioner Association days to become primary health organisations, or will they now morph to become provider network management organisations, or will another group of organisations develop that, take that role? Will it be a pluralistic future where, sort of horses for courses? Will the locality networks be geographical, or will they be communities of interest, particularly in the Māori and Pacific provider space, or meeting the needs of Māori by Māori for Māori and by Pacific for Pacific across the country? And so how will that interaction between the Māori Health Authority, the iwi governance partnership groups, and the kaupapa Māori providers, how will all of that work, and how will that interface with mainstream services? And lastly, how will general practice of today adapt for the enhanced primary care teams of tomorrow? So I think these are some of the things that need to be worked through, and taxing the minds of us that are trying to make these things happen. So in terms of locality networks implementation, there are 5 key areas that the Department of Prime Minister and Cabinet Transition Unit, led by Steve McKernan, with Deputy Martin Hefford, who many of you will know was the Chief Executive of Compass to Order PHO in the Wellington region for many years. So that there are 5 key priority areas that the locality networks are encouraged to focus on. So one is whānau with complex health and social needs. The first 2,000 days, so we were all for several years going, working on the first 1,000 days of just instant inflationary age, so that's just been doubled. And then distress and mental illness, people with complex long-term conditions, and the last years of life. So the messaging is that we all need to be focusing on all of these eventually, but there's quite a lot to pick off in one bite. So encouraging locality networks to focus themselves around one of these areas to get some runs on the board, to work out how to work together and then expand.
Should we try having a break from the heater with the sun coming in?
So in the money that's been put in budget this year was $46 million rounded up over 4 years to develop the locality approach. It's being described now, sort of the terminology has gone from locality networks to the locality approach. And there's $9.6 million for this year to establish 5 to 6 prototypes that are aimed to cover about 5% of New Zealand. So there's obviously a time, this isn't going to happen overnight, which isn't good to know. It's going to take more than 4 years though to get all these changes embedded. And this is back to what David alluded to, the short-term political cycle drives some of this, and that can be a problem for the real work that needs to be done. So what we know is, so the transition unit has gathered information. There was a call out to all DHBs and PHOs and other interested people, providers over the last month or so. It was probably 3 or 4 weeks ago, just prior to COVID, that all those 300 documents from across the country hit the transition unit's inbox, and they're being looked at to sort of get a sense of what kind of integration projects in this locality network space are happening around the country. That particularly when there's a strong focus on partnership with Māori as being a key thing that they're wanting to have information regarding. And then when the Māori Health Authority and Health NZ interim boards are appointed in September, if it goes according to plan, that they will be briefed on the summary of that information, and then there'll be a process over the following 3 months to select these locality network prototypes. And I'm wondering if prototype avoids the pilot the pilot issue that David was talking about. That might be interesting to talk about in the group discussion. Then the first, so there's going to be 5 or 6, and they'll go live early next year. What's not clear is who will be the chosen few. I suspect it will be groups of people who have strong connections with their Māori iwi partnership boards with Māori providers, where actually they've done a lot of the hard work already and are ready to go with work that meets, focuses on improving equity or achieving equity for Māori, and as well linked into the community. And what will the other areas that don't get chosen do in the meantime? So, what's my take on what this means for the Southern Health system? And these are very much my personal views. Yeah, just my reflections. So I want to look back to those of us that were at the last symposium or colloquium that CHeST held back in April, I think, and we reported on the midpoint progress of the evaluation of the primary and community care strategy implementation in the southern region. So that was funded by Health Research South to do a 3-year implementation evaluation. Sorry, I've just seems to have gone a bit dark. It's probably the sun. It's so sunny here in Dunedin. Okay, so you'll recall that those of you were there that we presented different streams of that work, and we are still near, life's got a bit busy since then, and the feedback on that, we're at the point of, as we said we would at the time, sending that out, but I'm giving you a preview of it now, so I do apologise for the time delay in this process. So at that midpoint evaluation, the key findings that were coming through is the way that the strategy was being implemented across the region, that we needed a greater focus on equity, and that noting that change takes time, and that a thought that it just takes time. So again, a 3-year horizon for, you know, bringing a more integrated way of providing health services in our region is probably 3 years we're going to be partway through. We will have got some good things in place, but the whole strategy won't be implementable in a 3-year horizon, taking a staged approach as opposed to leaping the chasm approach. That changes that improved teamwork, for example, clinical pharmacists, the health improvement practitioners, health coaches, community support workers, and that improved integration between primary, community and hospital care were the valued things that were coming through, and that a clarity of purpose and scope of the various projects was important. So where that was clear, the projects were making good progress. Where that was unclear, that was causing stumbling, delay, difficulty getting things off the ground. And then those present at the colloquium at the end in the discussion, we agreed that we should build a research and evaluation capacity within the Southern Health System, and that we should be linking that with our academic partners. So the University of Otago, Southern Institute of Technology, that we should pursue that in a kind of a co-arbiter of the South kind of concept, not the in slavish detail, but the idea of that had merit, and that that translating research and evaluation into practice would be key. We thought that this could be built around Health Research South, but that it would need an expanded role for Health Research South to become more than locality assessments and funding, and be broader than just Southern DHB and the Dunedin School of Medicine, and then, you know, to include the whole Southern Health System and academic institutions more broadly in our region. So I just wanted to remind ourselves of that, and then talk about possible locality networks that have been put up. And this is only to say that there are a range of different ways you can cut the cake. So there's nothing here that is anything except saying how can we look at the southern region. So you can look at it by existing DHB boundaries. You could look at it by council, territorial local authority boundaries. You could look at it by electorate boundaries. You could look at it by runaka boundaries. And you can look at it by what the Southern Strategic Plan put in place as boundaries. So what is it likely to look like down here? So what we know is that the locality networks are suggested to be between 20,000 and 100,000 in the initial information that was coming out from the transition unit. That iwi Māori partnership boards will be key partners in locality network discussions, and that Ngāi Tahu are considering currently how they want to engage with the health system in developing locality networks. So for us down here in Southern, we are actually at the stage of having those preliminary discussions with the Iwi Māori Partnership Board, which is our iwi governance committee at this stage in the piece, to say how are we going to work together to implement locality networks in our rohi. So what's not clear is how decisions about the locality network boundaries will be made locally. Will we be allowed to have smaller and larger locality networks if that's the decision? For example, Hokonui Goa is a locality network in many respects. It had the Hokonui Tuanui Highway has done a lot of work around integration, both health with social services and with the community, but they probably don't make the 20,000 mark. And Dunedin is more than 100,000 into, to sort of split Dunedin into two seems a bit surprising. So how's that going to work? And looking at our rurality, it may be that a locality network for one conversation is certain size, and then when you start thinking about sort of the way the hospital network with our rural hospitals and our urban hospitals overlies that, that we need a different lens for our network. So maybe we have sub-networks and supra-networks. I don't know how that will pan out, but I think we need to not be constrained by, you know, you can only have one view of a network because of our context is different than it would be in central Auckland, for example. So what might be a pragmatic approach for us down in Southern? So I think the realities about being a prototype, this is my personal view, is that I think that it's, you know, everyone will be putting their hand up to be a prototype when that call comes, but I won't be holding my breath for us to be chosen and putting all my eggs in that basket. I think it's really important that rather than try and be first cab off the rank, that we focus on developing our iwi Māori relationships across our rohe. So I think, in, you know, that in some areas that's strong, and in other areas that's less strong. And I think that's where we should be focusing our energy, because for the long term, that is going to be what will meet the needs of our community in an equitable way. And I think we need to focus on developing the building blocks. So that is something that, so there's work that happens at the locality network level, which is sort of capital L, capital N, who, you know, setting up the structure and the governance and the leadership of the locality networks, and bringing in, you know, the other government departmental agencies, the stronger public health focus, integrating hospital, social, primary care services for the whole region. But, you know, each general practice can work on its knitting, so to speak, and start to develop up these building blocks. And then thinking about what our locality provider networks and provider management network structure would be across the region as well. So, you know, from a general practice perspective, I think the questions are, and this is the stuff we can do now in our practices with our teams, and in Well South we can be leading these conversations, is, you know, how, if we were going to add additional roles to the team that we have in our practice at the moment, what would they be? And then what would the order, how would we approach that? What would we first add? So, as was the case on the West Coast when we had an integrated primary mental health service more than a dozen years ago, that was the single best thing that the PHO there ever did for general practice, was making mental health provision and primary care much easier. And we are now having the HIPs and health coaches and community social workers coming into our region, which is fantastic. And so the challenge is, how do we enable that into our small practices, which don't have the magic 10,000 population? And there's been a couple of examples of sharing in that space, and we need to develop that more. What's the role for clinical pharmacists, and how can they become a stronger part of the team? Our FENA roles. And then how can we develop more partnership with our kaupapa Māori providers? So can all of our practices, you know, look at their interface with kaupapa Māori providers in their area and strengthen that, and actually, you know, develop them as part of their broader team, or not their team, the team. What training and new skills do the GP team, and I would hazard this means the GPs who are maybe a little stuck in their ways, what training and new skills does the GP team need to be able to work in this different way? Expanded transdisciplinary, transsectoral teams. There are other questions that about IT enablement, but I agree with David that actually it's about the people, and you can, the IT enablement will follow in various ways, but I think it's about how we work together, how we develop a culture of one team across the broader system in primary care, the community care, and reaching more into our connections with our hospital colleagues as well, because that's when we'll really start to develop a whole of system, so the whole of the system for the Southern health system, and each locality having a whole of system approach to how care is provided to meet the needs of the individual communities. So I just want to finally swing back to the national view and just make a couple of closing comments or observations in that space. So some recent comments have been made about the money lately, and thanks to Tim Stokes for pointing this Twitter comment from Ian Powell, hot off the press. I think that might have been today or yesterday. Maybe it was yesterday, and I thought yesterday was today. It was a busy day yesterday. So Ian Powell, so many of us will know him as ASMS, don't know if he was chief executive or what his title was, but the leader of probably the most powerful union in the country, I think, the Hospital Doctors Union, which some general practitioners, for example, those of us working on the West Coast with the DHB were also members of. So removing patient co-payments can be justified when considered through the lens of a universal public health system. The structure of privately owned general practices as the means of delivering most primary care should not be used as an argument in opposition. General practice has to fit in with the health system, not the other way around. So that's I find that a really interesting comment from Ian. Yeah, that's very interesting. Again, I'd be interested in David's reflection on that, having worked with him for many years in his ASMS role. And then last week, Martin Hefford spoke to the GP CME South Virtual Conference, and there was, and this was quoted in New Zealand Doctor. So pay parity between employed GPs and senior public hospital doctors, quote, has to be one of the considerations in dealing with the GP shortage. Quote, I think if we are going to be serious about refocusing the health system on primary and community care, then we need to have parity in terms and conditions for the workforce. And he then went on to also say the same applied for primary care nursing and hospital-based nursing. So raising that, that aspect, which I think is the elephant in the room. And the last comment that I'd like to make is about change in the time of COVID. So the time, and David alluded to this as well, timelines for the reform are really tight, and 303 days time, that Southern DHB will no longer exist. And certainly for my work life in the last 10 days has been completely focused on Delta. And we don't know what's going to happen with that. We don't have Delta in the South Island, and yet I've, spent many hours every day over the last 2 weeks nearly now. So, have we got, as a health system, have we got the headspace to push on with these reforms? How concrete are the timelines? I mean, I totally understand the political imperative behind the timing of these reforms, but it's, I am just a little concerned about whether we'll have the capacity as a system to really embrace this and end up with the best solution for Aotearoa New Zealand in the circumstances. So lastly, I just want to swing back to Samua Gray, who is someone that I hold enormous respect for and kind of follow what he says and does through his career. He's the man that started, who said about screening programs, all screening programs do harm. Some do more harm than good, and some do more harm than good at a reasonable cost. So he is a pragmatic man. And his comment that I've always really, I usually have this up on the wall in my office, If you don't imagine, plan, and build the future, someone else will. So despite all the challenges that are facing us and the unknowns, there's also an enormous opportunity. I think if we can take on board the approach and comments that David was alluding to about one integrated healthcare system that we're trying to build together, then I think there is a real potential for better health outcomes in Aotearoa and New Zealand going forward. So that's all I wanted to say. Thank you for listening, and I'm really happy to take questions and comments at this point.
Well, Carol, thank you very, very much. Just coming back to the point you made earlier about having worked with David many years ago, he's mentored you well, because it was a terrific presentation. So thank you very, very much. And a lot of very useful information in there and insights into the current state of play from the perspective of a PHO, which is buried in the process of responding to the various expectations. So we will open it up for questions coming from the chat room. So please, if you have questions, put them into the chat room. I will just start out by asking about the funding question. So that is in many ways the nexus of the elephant in the room. I'm really interested in whether you're able to share with us thoughts perhaps coming through the PHO, but also your own independently around what's your thinking in terms of how funding needs to be configured in order to support the direction of movement with the reforms and the sorts of changes needed within primary care, right out through to how you've explained the need to be able to expand the GP team and broaden the horizons of general practice, shift services and scope of practice and so on and so forth, take away the patient fees, get the pay parity. So there's a heck of a lot packed in there. So I'm just interested in your reflections on the funding question.
Yeah, thanks, Robin. It's complex. That would be the first thing to say. Whether or not general practice is free at point of care or affordable at point of care for everybody, that's, there are different views on that, but it absolutely has to be affordable at point of care for everybody. I think it's crazy that in our system you get sick and you turn left and have to pay, or wait until you're so sick that you can turn right and get it for free by going to a hospital. So that's a fundamental inequity as I see it, and the paying for widgets approach is another barrier for good care. So as David alluded to, in the hospital context, if you're paid for what you produce rather than what your outcomes are, that makes you do strange things, and the same happens in the primary care context. So we are going through a interregnum, I suppose, where an in between, where hospital services are saying, okay, we need to have more services provided in the community, and either that's being asked to be done for with no extra support, or again a fee-for-service kind of approach. So I think we need to design a different model which says, okay, here enhanced primary care team working with your hospital colleagues and other parts of the system, we want purchasing outcomes rather than purchasing fee-for-service widgets. That I don't have an answer for it, but certainly if we can model how that would look and incentivize primary care to have greater focus on health promotion, keeping people well, people with long-term conditions, supporting them to look after their health conditions well, with support from the community, from Kaiawhina, from patient-led peer groups, all of those things, then we should have, I think, a better opportunity, better chance of having better outcomes.
Thanks, Carol. And I'm going to stitch together about 3 comments that have come in from Ray Anton, from David Hill, and Karen, not certain what the last name is. And these are around the separation between general practice and hospital services, or primary care and hospital, that seems to be in some ways reinforced through the arrangements currently in implementation through Health NZ. So I wonder if you just reflect on that question and how you see it from your perspective.
So is that sort of, as opposed to it being decided locally in the current system, actually the separation happening further up the tree? Is that the kind of?
Well, I think it's probably local as well. There seems to be a separation between the hospital and between the primary care sector.
So I think that regardless of the structure, who we have is who we have. We don't have any more health providers south of the Waitaki River and Haast Pass. So regardless of what the structure is, the same people are here to provide care for our community. The structures can enable or make it difficult to work across primary and community into hospital services. The culture can make it difficult. So you can have an enabling structure and a difficult culture. And without disrespect to anybody, my sense coming down south is that we've got both. And so we probably need to work on both. So it's certainly an interesting space to be working in, but lots of room for opportunity. I think things like COVID do actually make you work together because you have to. And I'm hoping that the experience of working together and having good outcomes will be encouraging people to keep doing that as time goes on. There's also certainly a willing group of clinicians in the hospital and primary care space who want to work together and are starting to have those conversations. So it's not going to be fixed overnight, but I'm confident that there's a good group of willing people that we can make some good progress in this space on. I think changing the power dynamic between the hospital being the castle on the hill and general practice being the kind of the little tents around and the moats around the hill to actually being partners equally will make an enormous difference. And don't get me going on generalism versus specialism. I think we need to be partners together, not one being predominant over the other.
So I'm sure this will come up again in the panel discussion. Another question from Tui Smith, asking about the existing barriers that you see to collaboration between primary care and kaupapa Māori providers, how you think these should be overcome in a practical sense.
Thanks, Tui. That's a good question. It's something I've been thinking a little bit about lately, realising, so a couple of weeks ago, so I've been in my new role for maybe a month or so, and so a couple of weeks, well, must be longer than that now, 3 weeks ago, 4 weeks ago, I've had the pleasure to meet the majority of the kaupapa Māori providers in our region. Still a couple I've yet to meet. And it made me realise that they do a lot of fantastic work, and that actually it's varying levels of penetration into the psyche of general practices in their areas, and there's a lot of opportunity there to do things in a more connected way. So I think it's about each other knowing what the other does, and actually spending a bit of time sharing the air when you're allowed to share air again, to get to know who the other people who are doing good work for your shared patients in your community is. So I think it's just a matter of people getting to know people and then working out, look, baby steps. Okay, so what are some practical things we can do for this group of patients that will actually improve patient outcome? And if we take that perspective, then I think that's the way to start moving forward.
No, thank you. I'm just watching the questions coming in, trying to concentrate on your answers while reading chats, and I wonder, how a good journalist does this when you hear these panel discussions on radios, the multitasking. So I'm going to read this one out. It's from A Ride, which, sorry, it's just popped down. Here it is, it's from John Coney. And so it's around the ability to build roles, partnerships and training in a context that seems to be predetermined before we understand how a primary care system actually works in practice. And so the question is along the lines of, I think, are we embedding much of the current activity without really thinking through the model?
Well, and that really comes back to David's comments about, if we're going to do things differently, we need to think differently and not use yesterday's solutions for the future. I think it's an absolutely a very valid point that we need to be mindful of. And I think because of the tight time frames around all of this, we run the risk of not thinking differently.
And just put up this final comment here, or question, which is around the GP workforce, and perhaps coming back to Martin Hefford's point as well around remuneration and pay parity. And so the question is around whether we need to strengthen pathways directly to primary care from universities, polytechnics, tertiary trainers. So would you like to comment on that? How we reinforce the pathway?
I'd love to comment on that. Thank you for the opportunity. It's slightly off piece, but it's connected. I think, and it's about, and the same may well apply in the nursing space and in other health professional space, but I can speak to how it applies in the medical space. So we need, 40-ish, it depends on who you talk. We need about 40% of our graduates to become general practitioners to just maintain the current model. So that's not talking about, I think the figure was 37%. That was some work Health Workforce New Zealand did a couple of years ago. So that's irrespective of, that's just doing more of the same. And I would argue that the future we need more generalists, community-based generalists, because that's where the work's going to need to be undertaken. Currently, our our second year medical students across the country, 20% of them plan to be GPs when they at the second year medical school intake. And by the end of medical school, so you could argue, are we even, if we need 40%, are we choosing the right kids? Because they're all capable, and a lot of the people that miss out are capable. So we need to be choosing the right people that want to end up in a career in community-based generalism, whether that's in general practice or rural hospital medicine. And then by the end of medical school, about 25% wants to become general practitioners. So that means we've made a small impact, but when you look at the weeks and training and the medical curriculum that are spent in general practice and community settings, it's a maybe I think 15 weeks out of, in the clinical years, there's, I don't know how many weeks there are a year, but it's more than 50 or 60 weeks. There's a tiny part of that time is spent in primary and community settings, and we currently are reviewing the curriculum, how it's delivered in Otago for years 4, 5, 6. And the number of weeks where students are spending time in primary and community care is hardly budged, and it's actually gone down by a week. in the proposal for Otago, for Dunedin School of Medicine. So we're not actually responding to the signals that the system, as a university, the medical schools aren't responding to the signals from the sector that we need more community-based generalists. And then in our early postgrad years, that figure goes up to about 27%, from 25 up to about 27 by the time someone is about PGY 6 or 7. So they're either in training or planning to go into training, specialist training soon. So every year we're 50 or 60 GPs and rural hospital medicine doctors short. And if we don't see that as a critical problem that we have to address, you know, jeepers, what are we doing?
All right, well, thanks very much, Carol. It's been a lot of good feedback coming in. So thank you very, very much again for your very thoughtful and insightful presentation today. You've raised a lot of, I think, really important questions, which, you know, clearly you're having to put a lot of effort into. So we'll see you at 11:15. Thanks again, Carol, and claps.